All right, so I'm picking up from 21. We ended at benzodiazepines, the interaction, again, to reduce neuronal excitability. I think I already talked about the different things that we use this for, and we're going to continue to add to this as we go, but there's your actions and your uses right there. You will want to dig into your book some for benzodiazepines and look at what nurses do for this. Especially, we want to focus on our assessment. What do we need to be on the lookout for our patients that are either being prescribed or have been on benzodiazepine? Again, our tolerance, some type of addiction, what kind of nursing diagnoses would we look at? What kind of planning would we have for this patient? Are we going to give them IV or IM benzodiazepine and then have them get up and walk right away? You know, we would not want to do that because patient of the side effects that can happen and the sedation that it can cause. How can I reduce or reverse this if I need to? Interventions, what I'm going to teach my patient, especially when it comes to alcohol and things of that nature that are going to interact with the benzodiazepine. I want to make sure that I'm teaching my patient the things that are pertinent to this medication, and then my evaluation. What are things that nurses evaluate on patients that are taking benzodiazepines? So this is the part where you need to dig into that in your book so you understand this stuff. And if you don't, make sure you ask me. So you have some different ones here you're going to find that are listed using non-benzodiazepines as a hypnotic, but still listed under benzodiazepines. So Ambien is the main medication of that. You can go ahead and use that or put that under your benzodiazepines if you'd like. We definitely treat it like one. It definitely acts like one. So you can also always put in your benzodiazepine cards, if you include that you put next to it, it's a non-benzo. It's not truly a benzodiazepine, but that we use it as one. And so you have your duration there, your usage. This is used to treat insomnia, but it's only supposed to be for 10 days or less, okay? Because patients their bodies get dependent on it to go to sleep. So we have to be exploring the different things with them and what they can do besides medications. And unfortunately, what happens many times is that because this ends up working, our prescribers out there just continue to prescribe without looking at the long-term side effects of these medications. So this right here is just a little thing on older adults. We will go more into this in Med-Surg too, but I included it here for you guys as well. We're going to keep moving forward on this. Interactions, again, alcohol and CNS depressants. So things that the nurse needs to do, interventions are listed right here for you for sedatives and hypnotics. And then our nursing process, again, as with everything else, you're going to dig into that for your drug cards. And then melatonin agonist. So this is going to bind with, help with the melatonin. That's a natural that's made in our body that helps induce sleep. You can also buy that melatonin right over the counter, and you'll see that given to patients at times. But the melatonin agonist here is Razorem. And so it's our very first FDA-approved hypnotic, not classified as a controlled substance, okay? So the rest of our hypnotics are all classified as controlled substance, and Razorem is not. Again, it's going to selectively target those melatonin receptors and regulate circadian rhythms. It's used for insomnia. It's not been shown to decrease the REM sleep, which is important because that's the cycle that people truly get rested in, where they actually have all that reset and where the things happen that we talked about before. Your adverse effects, you'll see drowsiness, dizziness, those are for you and for you to list for your cards. Can also be used as an anti-anxiety. Excuse me. So anesthetics, we talked about this. We've talked about this a couple of times now because we did this in Med-Surg 1 when we talked about anesthetics that were used. And I know we did a little bit of this in class as well. So your guys' purpose the things that you want to pull together for this is, what am I going to see in my patient that is getting an anesthetic? So again, we're going to depress the central nervous system, where we can alleviate pain and cause a loss of consciousness. So all the body functions slow down. From your class, we learned that there were 4 stages, and stage 3 is where surgical intervention, and that's listed right for you in your book. So you would go there and read through that to get a better understanding. So that was with general. Where local, our purpose is to give analgesia to a specific area. So it's going to block at a specific site, and typically your patient would be awake during local anesthetic. So this right here was from when we did this together in your class. It's all listed right out here for you. You can see the different routes we can do is inhalation, IV. We have topical and local. So topical is going to be some kind of a cream that would numb, and then the local, like we just said in the last slide, is going to be something to block just at one specific little spot. We also have spinal anesthesia. And then you'll notice that down here you've got kind of a list of the different ones that are in there. We have the spinal block, the epidural, the caudal block, and the saddle block. Though I probably would not go into details specifically for those, it's still good to know that we have these different blocks that are used. Many of those you'll only deal with, like with spinal, epidural, or saddle during some kind of childbirth processes, whether it's the person getting some kind of block like an epidural and then having the natural process, or getting some kind of spinal for a C-section. But you definitely want to know the differences between like an inhalation, IV, topical or local versus spinal, okay? I don't know how deep we'll go into that, but make sure that you're getting through that stuff in your book to know your different anesthetics. All right, so there's your positioning for a spinal. And then remember, balanced is where I'm going to use more than one thing in order to get the patient to have this anesthesia. So I may use something like a hypnotic, maybe given the night before. I may use some kind of barbiturate. There might be some kind of gas. So the idea of balanced anesthesia is to give the patient, like, there's going to be less recovery if I give things all around versus going just one specific direction. So balanced anesthesia has been shown to have less of recovery time for the patient afterwards. So there's your 4 stages right there, actually listed out for you for your 4 stages of anesthesia. This here will go through some of the stuff with inhalations that you can have. Remember, malignant hyperthermia that we're always on the lookout for. You definitely want to know about that and the questions that we would ask and what we would see. I know you were already tested on that, so that should just be a review. And then some IV stuff that's listed here for you. So you would be able to do for your drug cards, your anesthetics, and then list a few for each one. Like, so you'd have your IV anesthetics, which is going to include things like your Versed and your Diprovan. And then you'd have your inhalation, which was like your nitrous oxide. And then either use your book or your drug book in order to go through that. And remember, when you're picking your different things of what you're going to choose to do for those drug cards, that you're the things that are making sense to you. Why would I see this? What is it doing? Because that's the importance, is the understanding of the action versus just writing stuff. And I know I've said that 1,000 times. So there's your topicals, your locals. Those again are your blocks. So we want to have that the patient's going to be awake. You'll see the uses here for things like suturing the skin or for dental procedures. That's where you're going to see it the most, is going to be in dentistry, where they block for doing fillings or some kind of procedure. In the hospitals, we'll see it more of like either in blocks or for like seizures, like it said on there. So lidocaine is going to be your big one that we're going to see a lot of for that type of thing. And then your spinal anesthesias, look there that for your side effects, respiratory distress, headache, hypotension, all that's right in your book. I'm going to there's the list out of this. So you guys, I believe this we did right in the class. So you have the spinal block, the epidural, the caudal block, and the saddle block. Those are going to be your 4 different spinal ones that are near the spinal column. They all have something to do with the spinal column in one way or another. So you have those. And then again, as always, our nursing interventions, we're watching their level of consciousness, we're monitoring their respiratory status especially, but also cardiovascular, I's and O's, and then we may need to decrease for some patients, so we need to be careful with that, especially if I have maybe a liver or an older adult. And then our nursing process, you always want to read through that stuff. And then